in a series dedicated to competency and evidence-informed practice for integrative health professions. My name is Deb Hill, and I manage our project to enhance research literacy here at the Academic Consortium for Complementary and Alternative Healthcare. I wanted to cover a couple of housekeeping items up front and let everybody know that all attendees are in listen-only mode to control the background noise during the webinar. But we will be taking questions, and those can be typed in your GoToWebinar control panel. Should be on the right side of your screen. And our panelists will answer as many as possible towards the end of the discussion, but please feel free to enter in your questions at any point. So today's topic is really going to address what are the impacts of competency and evidence-informed practice on you as a practitioner, and what are those impacts on your profession and interprofessional care. So a brief overview, for those of you who might not be familiar, and I am going to keep this very brief today, of our organization. We'll go into this in more depth in the next webinar in the series, but basically the Academic Consortium for Complementary and Alternative Healthcare is an interprofessional, multidisciplinary organization, and we represent 5 core professions. And those include acupuncture and oriental medicine, chiropractic, massage therapy, direct entry midwifery, as well as naturopathic medicine. And basically, we work to help educators at our roughly 180 affiliated academic institutions and programs to best prepare graduates for interprofessional, team-based healthcare. So we'll talk more about ACAC and specifically about the development of our competency and evidence-informed practice on the next webinar. But today, I wanted to welcome 3 amazing panelists who are really at the forefront of integrative healthcare to discuss today's topic. So first, I want to welcome Regina Cobb. Welcome, Regina.
Hello.
Great to have you with us today. Regina directs the therapeutic massage program at the Community College of Rhode Island and received her master's in clinical social work from Simmons College and her bachelor's of arts degree in both psychology and criminal justice from CW Post University. She's a member of the National Association of Social Workers and committee chairperson for the Rhode Island chapter of the American Massage Therapy Association. And since 1997, Regina has served as a Red Cross volunteer, first responder for disaster mental health. And she is a coordinator for the Crisis Massage Team of Rhode Island and a coordinator of CCRI's Oncology Alliance team. Regina has practiced massage for over 17 years and taught therapeutic massage to students for over 13. She has her own private massage practice in Providence, Rhode Island. And in August of 2011, she was elected to begin the first oncology massage program at the Boston Medical Center and Department of Family Medicine and Integrative Medicine. So welcome, Regina.
Welcome. Thank you.
Glad to have you. And next we have Liza. Good morning, or actually good afternoon, Liza.
Good afternoon.
So Liza Dion is an instructor of medicine at the Mayo Clinic and nationally board certified massage therapist. She graduated from Sutherland Chan's massage therapy program in 1996 and maintained a private practice in Toronto, Canada for 5 years. Liza has been an inpatient massage therapist with the Mayo Clinic in Rochester, Minnesota since 2009. And the focus of our work is with oncology patients, utilizing a variety of techniques, including Swedish craniosacral and acupressure. Liza has been published in the International Journal of Therapeutic Massage and Bodywork and Complementary Therapies in Clinical Practice. And Liza teaches in the hospital-based massage therapy program at the Mayo Clinic. So welcome, Liza.
Well, thanks very much.
And Catherine Taomino. Welcome, Catherine. Glad to have you today.
Thank you. It's nice to hear you.
And she is the program manager for the Center for Comprehensive Wellness Integrative Therapies Program at Columbia University Medical Center. Catherine's been practicing acupuncture and oriental medicine for over 15 years, and she has been affiliated with the Integrative Therapies Program Center for Comprehensive Wellness at Columbia University Medical Center for 10 years, first as an acupuncturist and now as the program manager. She has extensive teaching experience, having been appointed faculty both full-time and adjunct at several AOM colleges. And most recently, she was an associate professor at the Finger Lakes School of Acupuncture and Oriental Medicine of NYCC in Seneca Falls. She serves as a commissioner and treasurer for the Accreditation Commission for Acupuncture and Oriental Medicine. And she has been a member of the clinical working group here at ACAC and also remains actively engaged in research and the use of acupuncture and oriental medicine and other integrative therapies in cancer patients. So welcome, everyone.
Thank you.
Thank you.
We're glad to have you all with us today. Just a brief overview of today's agenda before we get started. We're going to very briefly review a definition of evidence-informed practice. And I only have a few slides on it, but it's really just to ground us in this topic. And for those of you who might not have caught our previous webinars on this topic. And then we're going to discuss with our panelists really how they've utilized the principles of evidence-informed practice to integrate into allopathic medical centers, and how being an evidence-informed competent provider can really help you in integrative team-based healthcare settings, influencing professional opportunities to grow your practice as well as your profession. So again, I just wanted to give a very brief overview of evidence-informed practice, and just to kind of ground us in this topic. And basically, EIP is a process to help identify pertinent literature for your clinical case, but also incorporates both your clinical experience as well as your patient's values. So I like the schematic on the right, the clinical jazz, that when this all works together, it really helps you provide the best care, optimal care for your patient or client. And I view it as really as a way to help you sift through the literature and hone in on what is most beneficial to improve the health of your patient or your client. So basically at its heart, evidence-informed practice is basically five key steps to this process. And it's a process where the key component is really the clinical application of research. So it's a step a little bit beyond reading and staying current with the literature, but moving into the application of that research. So stepwise, basically there's 5 steps to the process, from identifying the question, the clinical question, to locating the literature, to staying current and being able to locate the literature depending on your question, deciding if you should really believe the study that you've been reading, determining how or if this might be relevant to your patient or your client or your setting, and then assessing the impacts of that decision. And so when we apply this to the multidisciplinary healthcare environment, we will add on also additional components of the integrative EIP competency that we've developed here at ACAC, and we'll discuss this more in our next webinar. But this is just a basic grounding in what we mean by the process of evidence-informed practice, and that really this key is that clinical application of research. And we do have further information. We've had previous webinars in the past that have addressed evidence-informed practice, and these are all freely available on our website, optimalintegration.org. And they're underneath our events tab, and you'll find a number of archived events on all of our projects. So I welcome you, if you'd like more information, to visit our website. But I did want to make sure that we leave lots of time with our panelists today to really discuss this importance in interprofessional care. And each of our panelists has really been on an amazing journey to where they are today at allopathic medical centers. And I thought I would have each of our speakers really share how they've integrated into the hospital, and specifically how you've utilized research or research literature to do that. So Liza, I'm going to ask you to start off about how you've come to integrate in the hospital setting at the Mayo Clinic.
Sure, thanks, Deb. So I'm going to go back to 2004. We didn't have massage in the hospital. This all started with Dr. Sant, who was a cardiovascular surgeon. He was head of surgery, and he decided his mission was to provide pain-free surgery to his patients. And he actually went to them and said, what's happening after surgery pain-wise? And almost all of them said there was no sternal incision pain. All the pain was upper back, neck, and shoulders. So he got together with Dr. Brent Bauer, who is an expert in integrative medicine, and he's the director of our program, and Sue Cutchell, who is one of the nurses with integrative medicine. And they wanted to bring massage to the bedside, but there was no evidence-based research at the time for them to do that, and Mayo said you can't just bring in a massage therapist and do this. So they decided to contact an occupational therapist, Deb Engen, who also had a massage therapy background, and they recruited her to do a very small pilot study. It was with 58 cardiac surgery patients. They all had open heart surgery, and it was a 2-arm study. One arm of the study was to receive 2 20-minute massage interventions, day 2 and day 4 after surgery, and the other arm would receive 2 20-minute interventions of quiet relaxation, and they were going to compare the two with pain, anxiety, and tension scores before and after. And just to describe what the quiet relaxation was, it was very simple. They put a sign, a do not disturb sign up on the door. The patient could have dim lighting and light music, and they actually stationed somebody outside of the patient room to make sure nobody interrupted them for 20 minutes. And the surgeon, Dr. Sant, was thrilled with the results because the massage therapy intervention won hands down, but he felt it wasn't enough of a sampling. So the next study was going to be a randomized controlled study, and this was with 113 open heart patients. And the very same thing, a 2-arm study. The massage group got the 2 20-minute interventions, day 2 and day 4, and the other arm got the quiet relaxation. And again, the results were fantastic, and they published the results, and that's how it all started here. But it had to start with that evidence. Otherwise, Mayo said, no, they felt it was dangerous, that perhaps the massage therapist could hurt the patient, maybe pull out a drain tube, a chest tube by mistake, something like that. So all of that was taken into consideration. It wasn't a protocolized study where the massage was protocolized. It was completely non-protocolized, and the massage therapist would do a 2 to 5 minute intervention, or a 2 to 5 minute assessment with the patient regarding where the pain was, what was happening tension anxiety-wise, and together she planned a treatment with the patient. And we've found with all of the studies at Mayo, doing the non-protocolized approach has definitely given us a lot better results. And I'll stop there.
Great, Liza. Thank you. Thanks so much for sharing that, and especially how this, it's really all started with the idea or the concept of wanting to bring this in, and then how you've gathered that information and shown that to the literature, and now you have an established program. So I really appreciate you sharing that. And Kathy, did you want to share a bit about how this has impacted your professions there at Columbia?
So I think that was really very interesting. I think that many hospital programs have a similar origin. The only thing I would add about our experience is that, which I love to share, is that one of the main sort of driving factors for developing our program was that here at Columbia, I work within a pediatric oncology, mostly within the division of pediatric oncology, and we're also in adults. But there was sort of an acknowledgement that patients were using CAM therapies regularly. Primarily, there was a concern about the supplements that all their patients were taking, and some of the MDs here got together and they actually decided to launch a sort of small level program, mostly with using nutrition and a little bit of massage, which there was not so much concern about safety, in the sense that they were going to look and sort of be a resource for patients, right? So the idea was that they would be more of a resource of information rather than of clinical interventions. That quickly changed, and over the course of the last 10 to 15 years, we incorporate multiple therapies, including acupuncture, supplement, aromatherapy, massage, exercise, nutrition, and at the same time we're also, of course, studying them. So we do a tremendous amount of research here as well. But yeah, it was sort of, I think the sort of birth of our program was sort of around the fact that patients were using these therapies already, and there was a concern about giving them a filter, a place to come to understand like best practices, where the evidence was, where the concern might be, and to be a resource, and then it quickly developed into something much larger. So thank you.
Wonderful, thank you. That's another terrific example of how it may start small, and then as you gather more data, you can gather more steam within the organization. So Regina, I know that you had sent along a couple slides for us to take a look at too, and tell us a little bit about your story and how you've come to integrate into the hospitals there in Rhode Island.
Okay, the slide that you see first happens to be a poster presentation that I did in 2014 at CAPC, and that's the Center to Advance Palliative Care, and that was in Florida. And pretty much what I did was, it was attended by mostly physicians, nurses, social workers, social workers, nurses, chaplains. And I was talking to folks about the benefits of massage. And a lot of people didn't know about the integrating approach that we were doing with massage in New England. So I kind of what I put up here is what you'll see if you can read it. We talked about lymphedema, neuropathy, compromised bodies, low platelet counts, deep vein thrombosis, and also scar tissue. And it got the attention of a lot of doctors there. So this is just something I did in 2014, bringing it out to a field that basically doesn't know a whole lot about what we were doing. Also, I looked at, I talked about what medical science does to treat individuals with health conditions, and then what the massage therapists do, followed by some of the research. So I just I did some eye catchers as far as to have people really look at some of the benefits, which reduce anxiety, eases pain, helps control nausea, improves sleep, and fatigue. And also what I had also, and I'm not going to show it yet, is I've also brought some research to follow up with that. On the left-hand side of your screen, it basically talks a little bit about our program, and on there we talked about using the Wong-Baker scale, the distress scale, all key things that are done in a hospital. So that was one of the things that I've done to promote some of the things that are going on in New England. But to back it up a little bit, one of the things in New England is that we had a real difficult time getting into any of the hospitals in the Rhode Island area where the community college is. So I did 4 steps, and my 4 steps were, I researched, before I even got there, I researched all of the leaders in our field as far as massage, and looked at things that were already working, especially things that were working in hospitals, massage schools, and clinics across the country. And some of the hospitals, there was about 5 or 6 hospitals that I looked at. One of them was Boston Medical Center, MD Anderson, California, Pacific Medical Centers. All of these places had integrative programs already started. I then advanced my education and became MLD certified and did a lot of continuing education with oncology, training, working with elders, and some palliative care. As a matter of fact, I got a certification. With that, I took this product that we had, or myself, and found different champions in the hospital. And I basically went to them and said, I have a product for you that I think that you would need to know about. And I basically met with one of the champions was the chief nursing officers. And what I did, and then if you can go to the next slide, is I was with probably 7 people sitting at the table. And I introduced some research that I had found. And one of them, if you can see to the right, it says, are complementary therapies and integrative care cost effective, which got their eyes. And it's a systematic review of probably over 300 studies. And so that got their eyes. And so I then basically said, here's the role of the massage therapist in cancer care. That's the next one. And then if you go to the next 2, it's basically integrative and behavioral approaches to treatment of cancer and neuropathic pain, and then neuropathic pain in people with cancer. And I showed them these things, or this research. It was from that point that they basically had said to me, this is something that we did not know. If you look at the research that I showed them, all of it is within the last 5 years, except for the first one. And it was research that they didn't have. With that, they basically said, how would you do this? And I basically developed a program and told him how I would go about working after I had my training already from Boston Medical Center, and how I would work in the infusion room. I work in the bone marrow transplant unit and in the infusion room. I'm sorry, inpatient. And so basically I developed a program which they approved, and pretty much that's how I got into the program. Into one hospital, and then the next year I was in a second hospital. So these were just steps that I took to get in, which I think is real important if you're trying to get into a hospital, is to find champions, come up with research, have a plan, and how you're going to execute it.
Perfect. Thanks. Thanks so much for sharing that, Regina. And I like how you've basically used the research to present your case,
Yes.
and then have become integrated into the system by doing that, and being prepared with the research to back you up.
Mm-hmm.
So I wanted to move on to a second topic. Actually, first of all, did Liza or Kathy, did either of you have a comment to piggyback off of what Regina has done, or should we move on?
Well, I like what Regina said about having champions in the hospital. I think that's one of the most important ways to get our programs to move, to get those champions that are willing to stand behind us and talk about what we can do.
Great.
Yeah, no, I think I'm good.
Okay, wonderful. So moving on, I wanted to, we've heard a little bit about kind of the process and how the literature might have helped this process in integration. I wanted to focus on kind of the importance of some daily activities. And I know specifically in this first bullet that I have up here to discuss really the difference between evidence and anecdote and why this is important. And I know, Regina, when we spoke a couple weeks ago, you had, and actually yesterday, you had some great ways to really think about this, and I welcome you to share those thoughts.
Well, a couple of things that I've done. Because I'm an instructor at a school teaching massage, what I try to do is encourage students to tell their story. A lot of times, students, I will ask them, well, how do you know that your patient, client enjoys the massage? Well, they tell me. And I said, well, you need to say more than they tell me that they like it. I said, you need to have proof when someone asks you. So one of the things I started to teach them is you need to have some quantitative measures and some qualitative measures. Some of the things that we might want to use are things that are already standardized. We have the Wong-Baker face pain scale. We use the distress scale. We have anxiety scales that we use. And I basically have the students start out with kind of looking at it and in their subjective questions and their observation, asking some questions so then they would have baseline data. And I found that this was really helpful for them to basically look at some of the things that their patients were talking about. And then what I would do with them is say, okay, now what I want you to do is research the literature. And I would point them to PubMed, CDC, the Massage Therapy Foundation, and then basically give them a simple form that assesses research. It has 10 questions, basically from looking at who were the authors to the limitations of a study. And they have to then come and present. And I found that that was a good way for students to have fun with what they were doing, because I would take what they're doing right now and then basically have them have ways to help tell this story, to quantify what it is that they were doing. And I found that this is one way that was very helpful.
Great, thanks. Thanks for sharing that. I like that. That's kind of putting a realism, basically, to the research. So Kathy or Liza, either one of you want to comment on that, or even on the second bullet that I have?
Deb, I'd like to comment on what Regina said, and I so agree. After the CV surgery study was done here, myself and Nancy Rogers, who also sits on ACAC, she and I were hired as the massage therapist throughout the hospital, and we did a study with the thoracic surgeon, and what they did pain, tension, anxiety, but what the study coordinator pulled from our information from the patient documentations that we did were quotes, direct quotes from the patients. And so those were published along with the actual pain scores. And what really changed here was how integrative medicine told the story of the patient with those quotes. And I think, you know, we do need the pain, tension, anxiety scores, of course, but if we can touch people in the heart with what we do, I think, you know, money-wise, it's really important for people to give us money and they want to see the pain scores and the changes. But when we touch them in the heart, I think that's just another deeper layer of what integrative medicine can actually offer for people.
Yeah, and this is Kathy, and the last thing I will add to that is that we had a very funny experience very early on when we introduced acupuncture services here. I was one of the inaugural acupuncturists, and then a colleague of mine was the other one. And I remember sitting in rounds, one of our very first times we were in rounds, and my colleague had said in front of many physicians, "Oh, acupuncture helped that patient's nausea." And one of the physicians turned around and immediately said to her, "How do you know?" And she said, "Well, I was there and I treated her, and the nausea got better." She said, "But she's taking all these other medications," and you know, she went through the whole list of things, and she's like, "You can't just say that acupuncture worked." And that was, as simple as that may sound, that actually defined like the next 5 years of our work here in order to, you know, sort of increase what we do and also just like expand our services. It was just something that her and I had not really learned in school about that kind of idea, and it just was a really, really interesting. It just goes back to what the other two are saying as well. So, but a pretty funny story.
I think that's so true too, that we're not taught that in school, and that's another. I think we need to talk to schools about having something like that in their curriculum so that the graduates are ready for this kind of work to further it.
That's exactly why we're here today with our project to enhance research literacy. So hopefully here at ACAC we are developing resources to help educators, to help guide them to a number of different resources to help implement this into the curricula. But this is exactly the point that you know, we need to make sure that our graduates are best prepared for these types of environments moving forward. So I didn't know if any of you would like to chime in a little bit about something that you do maybe every day to help to build time to keep up the literature, or things that small things that maybe our audience could take away today to help out to keep on top of some of the literature or practice in an evidence-informed way.
This is Kathy. I can start us off. This is a place that I feel really strongly about. It's really been a very important skill that I've developed and use pretty much daily in my position here at Columbia. So one of the things that has literally been probably the main reason we've been able to expand our services and actually treat, I mean, we treat very small babies that don't have immune systems with invasive techniques like acupuncture. So how we got there is captured in this bullet. So this was not something where we just kind of were able to walk up to a physician and say, "Oh, we're just going to give this patient acupuncture because they need it." We literally had to prove a negative, which was all around safety. So being able to very clearly articulate risk and benefit to all members of the healthcare team is of critical importance. And that was really one of the main barriers we had to get through. And the way that we did that was, obviously, first we went to the literature. There wasn't anything in the literature at that time, particularly around oncology and special clinical circumstances. There's a little bit now, but back in those days there was not. So we actually had to use this evidence-informed practice, which is basically be able to pull from the resources within our profession best practices, like common practices. So, for example, in thrombocytopenia, which is low platelets, in China, they use acupuncture to treat it, right, to actually treat low platelets. In the United States, back just 10 years ago, patients were routinely, and even still a little bit today, denied being able to have acupuncture because you had low platelets, right, that it would cause bleeding. So it was a sort of complete opposite, and we had to sort of marry those. So really understanding that and being able to speak across, you know, disciplines around those issues was really, really critical. So we did that by sort of informing about our medicine, right? Looking at textbooks and looking at things that were in the literature from China and trying to sort of, you know, get everyone comfortable, and they actually did. But we didn't have, it wasn't like we could go and do a PubMed search and then pull up this study. So we ended up actually publishing one of the very first studies, maybe the first one, in using acupuncture in the setting of thrombocytopenia. So it led to something really interesting. but just it wasn't something that was already in the peer-reviewed literature, so to speak.
Thank you so much for sharing that. That is, you know, when we talk about the informed aspect of evidence informed, and you take the best of what you have at hand, and then you use that to help guide you along with your experience, as well as what your patients are looking for. So thanks so much for sharing that. Did Liza or Regina, did you have any other comments before we move to the next topic?
I would like to say one of the things that I did because of my program in the outpatient. What we did is my program is a 40-hour, 10-week program, and so at the conclusion of what we were doing, because it was very interesting, because everybody saw us in the hospital. We were documenting in the EMRs, electronic medical records, but really no one knew exactly what we were doing. And so what I did was I basically, at the conclusion of it, because we were tallying how many people we worked on, how many males and things like that, I put on poster boards basically a graph. And I went to 3 different meetings that the doctors had, and then the doctors, the nurses, and things like that, which were attended by probably at least anywhere between 6 to 12 people in the 3 different meetings I had. And I said, this is what we're doing. And so I told them I had 119 patients that we were working on. We're using their pain scale. We're using their distress scale. We had surveys, and these are the results that we found. And so from them looking at the pain scale, looking at the distress scale, and what was very interesting was chemo-induced neuropathy that 50% of the patients had. And so with that, I brought what the research is saying, and I said to them, you know, we have something here. And when we're working with the patients, and I tell my story, when we're working with the patients, I've seen a difference. So I gave an example of a woman that was sitting there getting her infusion, and it was lunchtime, and she was trying to open up a bag of potato chips with her teeth. And I walked over and I says, can I help you? And she says, look at my hand. She goes, I can't even bend my fingers because they were so swollen. And I said to her, you know, so I did the assessment for some pain, and she was a 9 out of 10. And I basically said, have you ever had massage? And I basically looked at what was going on in her medical records before I touched her, and to rule out lymphedema, because she also had swelling in her arms. And so we ruled out that. I talked to the nurse, and I said, well, let me show you a couple of techniques that we do as massage therapists, because she had not had it before. And so I worked on her hands for probably, let's see, it was 10 minutes on one hand, 7 minutes on the other hand. And I just asked her, do you feel a difference? And she was like, I'm feeling sensations. Matter of fact, I can bend my fingers. Her 10 went down to a 6 in one hand, and then it's a 6 in one hand, the other one stayed at a 7, but she could bend it. And then I gave her some exercises with a ball, and I also showed her how she could work her fingers too. It was with that explanation that I explained to some of the doctors that this woman was able to then have some sensations, is when they said, Regina, let's take this further, and let's get a baseline on more patients that we have. So the next time that you come in, can we do this? So this is what I'm doing right now as far as one of the facilities I'm working on. We're getting a baseline on all of the patients, it's random, that come in that are getting chemo, and we're trying to find out who gets peripheral neuropathy and who doesn't based on the medication and things like that. I don't know the outcome yet because we're still doing it, but that was another way for me to inform them about what they had there, back it up with the data that's in the research that's out there, and then them taking me to the review panel, internal review board rather, to say, I think we might have something here, let's look at it.
Thank you so much. That That's really great. A really great explanation on how you've done the research, and then you've taken what's in clinical observation, and now you're doing further research to gather the evidence, some evidence that doesn't that isn't existing. But you had already checked that out too as well. So thank you so much for sharing that. And do we have any other comments from our panelists before we move to the next topic?
This is Liza. I agree with both of what Regina and Catherine said, and I think a lot of this is education of other healthcare practitioners, because they don't really know what acupuncture and massage can do or can't do. I think they often know what the contraindications are, but they don't know how much really can be done with a patient in this kind of setting. And we do a lot of pain talks with nurses. We teach them how to do very simple relaxation techniques with their patients. And even this, the medical personnel, they'll consult us for a deep tissue massage, and we know that deep tissue isn't appropriate. Maybe the platelets are really low. There's, for whatever reason. And that's a great educational component that we can have to bridge the gap between ourselves and those other healthcare workers. And I think the more that they learn what we do, what studies have been done, and what studies could be done, I think that gets the word out even more.
I agree.
You're absolutely right. And being able to, as we've stated a couple of times here today, being able to know that literature and know what's available and what needs to be done yet, I think is a key component of that as well. And then using your skill set to also be an educator, to educate others about your own profession based on the evidence that's available and knowing what's there and what needs to be done. So thank you so much for all those great comments. I wanted to move into one other topic, and that is moving on. Is basically, we've heard a lot about how about what we're doing right now, but also where do we go from here? Basically, how do you grow your program? And then I know that each of you has grown your program, and the role that research or research literature has really played in helping to grow throughout the hospital. If you wanted to address this issue, I'll let you all take it away from here.
So this is Regina. One of the things I had alluded to earlier is how do I grow my program, is that I do things like webinars. I do go to different local functions. I call it my dog and pony show, but I have a PowerPoint that I take to different places to talk about the benefits of massage in a hospital setting. I talk about the safety issues. I go to different arenas that mostly would not hear about the benefits of massage, and so that's some of the things that I do out in the community, is attend different organizations. And matter of fact, some of them I presented in front of physicians, outpatient physicians. I've also, matter of fact, I just presented at the Crown Plaza Hotel. So I get on people's documents, on their dockets rather, so just to talk about it. And it could be brief, anything for 10, 15 minutes. The other thing that I do is in the hospital, I'm a firm believer that there's a place for us at the table. And if we don't try to get into some of the meetings that they have, and even if it's 5 minutes, I spend time trying to figure out when the meetings are, and I ask, can I, and this is in the hospitals, can I just present some information about what we're doing? And so with that, I've been able to attend several meetings in-house at the hospitals, and people know more and more what we're doing, and now things are opening up a little bit more. They're saying, well, Regina, we're seeing that this is working here. Is there a way that you can show family members how to work on their loved ones? Because that's one of the things that we see that's missing when a family member starts to have complications. The family moves away because of fear of hurting them or fear of doing something inappropriate. And so I'm always open to say yes, that there's ways that we can work with them. So those are things that I wait for the hospital to ask me, or I present things to them, and then I try to find a way to accommodate it.
I think, Regina, too, about the word of mouth is so important between patients and between the healthcare workers in the hospital. We've got 2 hospitals in the Mayo Clinic. And when we started, you know, it was just with CV surgery, and the surgeons paid for all of the massages, so there was no cost to any of the patients. And then we grew into thoracics, and those surgeons were happy to pay for it for their patients as well. And then it grew into colorectal surgery, but each of those departments wanted evidence-based first. So big randomized studies were done in both of those before they would take us on. And once that came forward, then they hired us there. But Mayo said, you know, everybody should be receiving this, not just a certain group of patients. So they had to find out if there was an appetite for people to pay out of pocket. So another pilot study was done with post-mastectomy patients. And of the patients that were in that, I think there was 60 patients altogether, only 2 said no because of the cost. So that was enough for Mayo to say, okay, that's enough evidence, go for it. And now it's offered throughout the hospital. But I think if we had not done that pilot study, I'm not sure if our program would have ended right then and there. Again, it takes us back to evidence-based research. And Mayo would not have gone for it unless they had, that we published. That publishing is so important with the evidence-based research, because it takes it out of the anecdotal and takes it in that other realm of, okay, here's some proof, this is what's happening. We did pain, tension, anxiety scores, of course, with them as well, but really it was a fee-for-service randomized pilot. And then after that, we've been doing more research with the breast surgery patients and reconstruction patients. And I think we're growing our program with education with our other staff members, like I mentioned, but I think for us it's really the studies that are keeping us going and being published. We're publishing articles, mini cases that we publish. It just, then as Regina said too, it's kind of the dog and pony show in a way. You know, we can bring this forward when we're talking to different nursing populations or the medical personnel. This is what we can offer your patients. We've already done this study. This is what our results are. So what do you think? And that's how we're getting our consults from the doctors and the nurses, from doing that, from showing them those results.
The other thing I want to say really quickly is we also worked, we had a day where we worked on the physicians, the nurses, anybody who had time to come in on this, I think it was like a 2-hour span. And then we explained to them exactly what it is that we do different from deep tissue. If this is your patient, this is the techniques that we would use with someone who was frail or compromised. So we talked their lingo so that they understood, that we understood exactly that safety first. That was another winner. And we also have a couple of physicians that are now going to seek massage themselves because they realize the differences, because we do work on them too when we have time. Work on the patients first, and then we work on the doctors if we have time, or the nurses. And that was another way to proof in the pudding.
This is Kathy. So I absolutely agree with everything that's been said. We also, just to reiterate how everybody's experiences overlap, is we also treated all the staff very regularly for quite a few years in the beginning of our program. Helped a lot for reasons you already articulated. The only thing I would say is that we've been really focusing on hospital settings, and I would add that I believe that everything we're saying is really applicable to private practice also for some of the attendees who might be in private practice, because the one thing that I'm sort of sitting here thinking in my mind is communication. So I have overlap in experience in private practice and hospital settings, and the same rules have applied. So being able to communicate across disciplines has been the single most important factor. Now that means to communicate, be research literate. It means to be really articulate about risk and benefit. It's being very knowledgeable, but also being able to communicate your knowledge to, nurses, doctors, all members of the healthcare team, and all allied health professionals. and administrators. So I believe that that's like, you know, probably the single most important skill. The thing about using evidence as a private practitioner is that, and that it's the same, is that, you know, we're all sitting here telling you research, 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 which is true, and we'll throttle research studies at our colleagues in the hospital setting, but I also do that in my private practice. So everything, I just wanted to sort of not lose that. So if I have a patient, an oncology patient that comes to see me privately, who says, you know, my physician has a concern about such and such, I will do the exact same process that I do here in the hospital and communicating with the physician and sharing, you know, stuff from the literature and things like this. And it's very, very successful, to the point that, like, the first time I ever see a patient, the very first thing I do is connect with the physician by, you know, snail mail. I still do the old-fashioned way, and it works very well for my practice. And just letting the doctor know, and also just kind of sending them anything that I have in my little bag of tricks in the literature that I think would be relevant to this particular patient. What that does, and the last thing I'll say, is it establishes a trust between clinicians, because in my experience, physicians and other members of the team, even particularly the person who's responsible for the patient, it's not that it's not that they don't want their patient to receive CAM therapies, it's that they don't understand its safety for the most part. So I feel if we all just always operate from those shoes, we can be very successful in how we expand these programs and communicate with other allied health professionals. Just always knowing that one piece, that it's all about being able to, but if they don't have to understand our medicine, they have to understand that we're safe and that we understand our medicine, kind of thing. So, and I guess we need time for questions, so I'll stop there.
I just want to say quickly, thank you so much, Catherine, for talking about private practice, and I couldn't agree with you more. And I think in terms of massage therapy, we try to bring it up a notch from the sort of the fluff and buff type of thing, or the spa type that it's often seen as. And I think you're so right that talking with doctors when you're in private practice like that, and talking with your client or your patient and showing them research that's been done about what can really be, what kind of results we can get with doing these practices. I just couldn't agree with you more.
And just to say quickly, I have lots of relationships in my private practice with doctors, and they say it is helpful. And even if you're not giving, if you can't pick up the phone and talk to them, snail mail with information. They say that they do look at it, and they really they respect the profession more when they know that we're looking at the safety concerns also, and they like the team approach.
And the transparent approach.
Okay, yeah. Go ahead. Yes. So these are all really great points that you have brought up here this afternoon, in terms of being able to articulate your risk and benefit, and making sure that you're practicing in an evidence-based manner, and especially when you present yourself to those that are outside of your community. So we did want to leave a little time for questions. So I wanted to summarize, and I do want to say, anybody who has a question, please go ahead and type that into the panel, and we're going to answer those as many as we can here with what we have left in time. But I do want to summarize kind of what we've covered today, and kind of wrap it up from here. Is that we did a little definition of EIP, but I know Regina had shared how she had utilized the poster and brought in studies to back up the benefits of massage therapy to help integrate this into the hospital setting there in Rhode Island. And I know Liza had shared about how the program really started from a research study and then has grown, and also Regina on the more data that has been collected. And then I know Kathy, we had shared also the importance and brought up this continued importance of communicating that risk and benefit, and how important that is to not only integrate, but also to stay and progress with the profession. So I hope that those of you who are with us today have, through the discussion, you've gained some insights into the role that EIP can play in these multidisciplinary care environments, as well as in your own professional growth. So with that, I did want to mention that we do have another webinar coming up in 3 weeks on November 17th. And this one is going to take a closer look at our ACAC competency and evidence-informed practice. And this was a competency that's been developed by ACAC and has been endorsed by all 5 of our professions. So hopefully you'll be able to join us with that, and we'll detail that in a little bit more detail in a few weeks. But I wanted to thank all the panelists that have joined me today. and thank all of you who have been on the line. And I do want to go ahead and open this up for some discussion at this point. So Jennifer, my colleague from ACAC, is also on the line. If you have a couple questions that you could feed us, that would be great. Jennifer? Okay. So let me go ahead and pull up some questions here. Here's one that we have. I think, can everybody still hear me?
Yes.
Okay, perfect. What happens when the definition of evidence is too narrow? For example, low back pain is defined as the lumbar to gluteal fold, so all tests such as the lumbo-pelvic pain do not include the thighs. I find that low back pain at the hip or area is of great importance in low back pain, yet evidence-based studies such as those by Andrew Fleming do not take this into account. So if I looked at the evidence-based literature, I find nothing. So is the literature slanted in peer review, or can miss other important evidence? So I don't know if any of you would like to take that on and address that that question basically of is this too narrow, and what do you do when the evidence is not really focused on your clinical patient at hand?
Do your own study. I know, but it's hard, and especially not so much acupuncture, I don't think, but massage. It's relatively new what we've been studying. I think we just all have to kind of put on our seatbelts and go for that bumpy ride of trying to figure out how do we do more studies then and get more information out there. This may not be a very good answer, but I think it's true.
What I have to say is that the Massage Therapy Foundation is looking for people who have situations such as yourself, and if there was just a small number of people or a case study, they're looking at helping individuals do their own study and to get some of it published, and they will guide you to make sure that you are doing it in a way that meets all standards. So that is one avenue for massage therapists to get their information out there so they can get more feedback and help.
And I'm going to just go back to my communication, because actually in acupuncture we suffer from this, quite extensively, because most of the, the research, clinical trials in acupuncture have been protocol-based, and we're not a protocol-based medicine. So when you have, a physician saying to you, well, why, you should use this point prescription, or acupuncture wasn't good for knee pain, and you're like, yes, it is. Being able to really to deal with that is actually quite complicated. In my experience, and this goes back to the communication skills, having the skill to actually discuss that, and this goes back to being research literate, like that you're very clear, and this person who's asked this question clearly is, you fully understand the research, you can critique the research, and then you could speak to why it may or may not apply to the situation at hand, is actually the most important thing. And then of course we have to do studies, retrospective reviews, case series, all have to start, absolutely, but the first step too is to really be able to assess the literature and then communicate that, which I think is something, at least in my profession, we don't have very strong skill sets in.
Thank you so much for all those great responses and bringing out a lot of great points about the being research literate and communication. Jennifer, did you come back on?
I did. Can you hear me?
Yes.
Okay, great. Sorry about that. I had technical difficulty there for a moment. The next question is, when we consider the massage claims, the venous flow is accomplished by pushing the blood through the veins. This is the most common explanation in peer-reviewed, evidence-based literature. Could a more probable explanation be that the relaxation induces the arterioles to open and the blood flow is then increased? Is our focus too narrow? Could evidence be slanted to conform to the present theories? If so, when is evidence-based really anecdotal?
Well, that's a good question. It's intense too. I don't know. I don't know what to say to that. What do you think, Regina?
Well, it's very difficult, and because data, we're always continuing to do data based on what we found, and it does seem like it's narrow, it could be slanted. What I say to that is, it's a complicated question, and I don't really have a clear answer on that. And again, this is what medical profession looks at, the research, and I know that's one of the things that, as a integrative professional, we kind of push back on it. But those are the things that we have to do and try to figure out the answers to something like this. I don't really have a clear answer.
And so many, we can call them assumptions, I suppose, of what massage has been known to do. It does come into question, I think, the more and more research that is done, that we start to say, well, wait a minute, are we really increasing systemic circulation here, or is it just local? And, you know, for years we were telling people that we were increasing it systemically until more studies were done to change what we were saying about it.
This is a tough question, and I think what you just said is spot on, and brings to the need of also making sure that you stay current with the literature, because there is change over time, and that's the most important part of staying current. So Jennifer, did we have another question?
We had a few come through at the end here, lots of great comments and questions. There's an interesting one. How can private practitioners contribute to research?
Easy. I think Regina spoke to that too, with the foundation offering money for case studies or articles is a great way. You just start small. It's like we started here. We started with a little pilot study, pretty inexpensive, fairly easy to do, and then from those results, get that published, then you can move into something even bigger. And start with your passion.
Yes. And a case study is only one person. You can have one person that you see some great results, and they want to hear it, the foundation, and they'll help you be able to publish it.
So there's a movement now in research towards the N of 1, which is basically the single case report. That being said, we've done a case report here at Columbia. We're having a difficult time getting it published because it's a case report. And it's quite good. So I think that I've been talking to some colleagues, and I really feel that the professions, each individual profession needs to organize themselves, and actually doing a small pilot, we're saying, and maybe a case series is going to be better. So there's all this chatter like, yeah, we all going to do case reports, this is great, and everybody's like, the N of 1 is the new hot thing in research, and then no one will publish it. So I still think we're at that challenging stage, but you know, case series is what I'd throw out back at you with with colleagues or whatever. Coming up with, say, low back pain or whatever whatever it is, I'm just thinking off the top of my head, and because all the publications that we've contacted would be much more interested in a series, not a single case report.
Yeah, agreed.
Yes. The other thing is, I know that people are looking for, I think NIH or a few other places, I'm not sure, and I'm going to go back to the Massage Foundation, that people are looking for people to join into their studies for massage therapists. So they are calling for massage therapists that are practitioners that may have people with low back pain. I would encourage you, again, to go back to the Massage Foundation, because that's exactly what they're looking for. So you can be a part of somebody else's study.
Cool.
Great. I think that's all wonderful points, and I thank you for all the great ideas that everybody shared. We are at the top of the hour, so we're going to go ahead and conclude our webinar. But I did want to say thank you to everybody, all of our wonderful panelists that have joined us today, and those of you for joining us for the webinar. So thanks so much, and hopefully we'll see you all in 3 weeks. Thanks a lot.
Thank you so much.
Thank you so much.
Thank
This was
you.
a pleasure.